I'm talking about kind of an endovascular aneurysm repair and kind of a background of it, no disclosure. So clinic, as you will know, is critical. For if you want a sustainable career in VIR, to do the right thing, you absolutely have to have a clinic. You learn the natural history of disease. And I think that's the power of clinic. That's what I've learned from my graduates. They learn natural history of disease. A couple of things. One is follow up once they're screened. If you're seeing aneurysms, you have to follow them once they're screened. You have to also follow up after your intervention and admit to your own service and feel comfortable with that component. I think these are all kind of important constructs. So this is our clinic on the third floor of this building, and this is beautiful Sunset Boulevard. And you can see the palm trees on that, and it's right next to the Church of Scientology. You can see this is our clinic, again, alongside our general surgery and plastic surgery colleagues. And this is just one of our office rooms where we have the patient sit, the family sits next door. We often have an ultrasound, we examine them here, we talk to them, review their scans with them, go over their labs and everything with them, and again, do an exam. Now, I think this is an important construct and something you should really understand. It is what's called the life cycle of VIR. This is an historic thing and a construct that if you understand, it'll make a lot of sense. And what that means is basically we have generated ideas or procedures, and you'll see these new procedures, genicular artery embolization, or whatever it is, MSK, it doesn't matter. Develop, there's a lifespan and it starts migrating out and there's a residual. And why is that? We're innovators, but then we lose procedures. So it's very important in two things. One is we got to transform our specialty in a fashion. This was a talk by the great Andreas Adam, who was the head of BSIR before. And what it was is we didn't own the disease. We focused so heavily on pegnomastic and kind of these rare skeletal dysplasias and not enough time on the clinical side of things or the procedural aspects of things so we could really hone that aspect of it. Similar to radiation oncology, that's why it kind of became a new discipline. So we really need to get the physical exam to get good outcomes. So what did that entail when I wanted to kind of have a sustainable career in aneurysm disease? I need to learn that disease. So I read all the guidelines for blood pressure management, diabetes management, atherosclerosis, the vascular medicine textbooks, et cetera. And I learned the level one evidence. I think that's exceedingly important because we're scientists and we need data to drive it. You saw the amazing amount of data in the stroke literature. It's profound, and the number needed to treat is so low. So the impact factor is important. But look, how do you screen? Does it make a difference on a population basis? Yes, it does, based on mass. Adam, UKSAT, what size do we fix? Data, level one evidence in a randomized fashion showing us when to fix these aneurysms. And then looking at endovascular versus open, EVAR1, OVER, and DREAM showed what the benefits of one versus the other are. And these are all the randomized controlled trials and in pretty big journals, including the New England Journal of Medicine and the Lancet. So what does medical management entail or look like? It basically, if you look at it, can everyone hear me?
Yes.
Okay, so high-intensity statin therapies, these are game changers, PCSK9 inhibitors, ezetimibe, statins. They will reduce cardiovascular, cerebrovascular events, right? Antiplatelet therapies such as Plavix and aspirin or clopidogrel and aspirin, even low-dose anticoagulants like DOACs, like rivaroxaban, have now mortality benefits in the PAD population. So you need to know these drugs. And clearly smoking has a lot of ramifications in the patient population, including COPD, cancers, vascular disorders, heart attacks, and strokes. We can prevent these events. And by counseling and smoking cessation, varenicline, nicotine replacement therapy, bupropion, and certainly blood pressure management as evidenced by the HOPE trial, heart outcome prevention events. So we have level one evidence, and we as clinical physicians who are taking care of these patients as vascular and endovascular and interventional surgeons need to provide this construct to patients. Now, one of the things that's been exciting is as we developed SRRFS back in 2009, 2010, we've seen a dramatic increase in interest from medical students, residents, and now pre-medical students. And we're really excited about the WCVIS being part of this movement. And what does that showcase? It became, well, interventional radiology or vascular interventional radiology became one of the most competitive specialties and comparable to orthopedic surgery, plastic surgery, neurosurgery a few years ago. But what is the paradigm that's occurring? It needs to continue to occur. And clearly, we still have a lot of work ahead of us as all the programs haven't established it because we're always behind. Humans are afraid of change. We're not ready to adapt the driving, auto driving cars. We're not ready to adapt these new technologies. It always takes us time to change. But more clinic throughout, the weekly clinic, as we've established, the half-day clinic in Zaim in Austin, and Karthik can tell you more about that. Even Mazar Tian, more ICU throughout, as Dr. Desai had said, more procedural integration. We get 20 months. It starts in medical school during your MS4 year through surgical internships where you get vascular surgeon into your first 3 years of integrated training. So what are the tools that trade in when we're doing aortic work? Well, the BOVI, the low dose ophthalmic cautery. the snares or micro snares to form the circles around the graft. These different covered stent grafts are really important, right? These help you to prevent leaks. And this is a great device. It's a kind of an endovascular suture that we can put in the artery to close the hole that we make. Different types of wires and different types of neuromodulation. So because of the leg ischemia that occurs from a profound amount of large sheets, after about 4 to 6 hours, we may have to recannulate the SFA and reperfuse the leg. Because of the neurologic compromise that can occur from a thoracoabdominal repair and spinal cord paralysis, we need to be ready to assess that with near-infrared spectroscopy in the lumbar musculature or in the brain. And this is a publication that at the time, my former resident and I had published in a JVIR, looking at cerebral spinal fluid management in this patient population of reduced event rates that we were having. So I'll just give you an example. This is a 70-year-old male who had a prior ascending aortic repair, and his primary care referred to me and Dr. Consagra's VR clinic. Dr. Consagra is kind of his primary interventional physician, resident physician. You can see he had bilateral iliac aneurysms, pretty sizable on the left, 8 centimeters. So his risk of rupture is very, very high. These are the different graphs that we had proselytized using. And the beauty is this technology keeps on evolving. During our residency, you'll see more and more of these changes by the time you're faculty. The game will continue to shift. And this is a bifurcated iliac branch excluder that I used bilaterally. This is the device right here. So now we're able to preserve the pelvic flow. Before we had to block it off while fixing the aneurysm. This is an example. We put the sheath in you can see the sheath. These are the aneurysms here. And here we go above and up and over. We catheterize the pelvic artery while preserving flow to the leg. And we do the same thing on the other side. So we have 2 little baby grafts on both sides. And they would connect kind of like you're doing a Lego. You're connecting all the pieces together. And here we have preserved pelvic flow and AAA flow. And this is still my patient. He has some other issues dealing with, including a retrograde dissection and a type B that we're having to navigate as well. This is another graph. So before 95% of aneurysms are below the kidney arteries, and you want a nice cylinder of healthy aorta to fix it in. This is a patient who doesn't have that. He has what's called a pararenal or juxtarenal aneurysm. So now with these new graphs that have holes made at it that you decide based on the CAT scan of that specific patient, you can determine where the holes are going to be, how big they are, and how far apart they are. And we get through that hole. This is all fabric except for the hole. And we put sheets in and we put stents in. And you can see the stents fill the hole. So now you're preserving the kidney arteries, but you're getting a sealage in a healthy part of the aorta. So that's pretty exciting. And we kind of reinforce distally. This is another patient. We have to fix leaks in patients we've previously grafted because they're living longer and longer because we're putting them on statins, ACE inhibitors, antiplatelets, and screening them for cancer. So we're doing a job and telling them to stop smoking, but their aorta will continue to degenerate from the aortic valve all the way down. It's going to happen. It's just a matter of time. We're trying to slow that process down. So this patient, we actually modified a graft, taking a fenestrated graft that was made by the company with the celiac and SMA holes for the intestinal arteries and made ones for the kidney arteries. And then we deployed, again, in a similar fashion, sheets through the holes into the artery branches like this, and then deployed these metal stents. You can see these little metal stents. And they put a kissing bridge between the fenestrated modified graft and the pre-existing graft. And then, subsequently, the patient had a little leak, and this is the graft here. You can see the SMA stent and the kidney artery stents there, but the aneurysm is excluded. She came out later with what's called a type 2 endoleak, which is a back bleeding from a lumbar artery. My colleague, Dr. Lamb, got into and injected a little bit of liquid or glue into it to block it off and stop the leak. It's another gentleman. Our patients are sick. They have heart failure, lung disease, COPD, hypertension, diabetes, kidney disease. And so they're sick. And so we, as vascular interventional and endovascular interventional surgical types, will need to be very comfortable with ICU care. Growing type 3 thoracoabdominal aneurysm in a very sick patient. So they obviously can undergo surgery. And you can see this is the aneurysm here. These are the visceral branches, the kidney artery branches here, all in aneurysm. So what we did is basically we make holes using this ophthalmic cautery at clock positions and distances based on the CAT scan unique to the patient. And then we suture a little circle around it. This is like the fenestration. And then ultimately we'll cut these viabonds or cover grafts and suture that onto it. Okay, so it's all kind of predetermined. This is what's called a 4-branch endograft. And then once we do that, we deploy the graft, deploy this one with all the circles that we made and the branches, go from the arm get through the holes in the intestinal arteries and the kidney arteries. And we had a hard time finishing the left one. So we had to come back, modify another graft, and go from below to fix it. And you'll see that here. So this one's floating. I'm just going to keep on going here in the interest of time. This is another one, so that now we could access the left kidney artery. And here we're able to ultimately stent the left kidney artery. So we've done renal and SMA and intestinal branches and kidney branches from above and below. This is what's called a snorkel. This is a 60-year-old ruptured aneurysm. This is all blood in the retroperitoneum. And you'll see this is the scan. You can see here's the burst artery, and here's the blood in the back in the retroperitoneum, and it's the size of the aneurysm. Guy's pretty sick. So what we did was we put a sheath in from above to occlude the artery in case his blood pressure drops. And we put sheaths from the arms and then cannulated both the kidney arteries. And then we deployed the stents here. You can see here stents into the renal arteries and the stent graft into the abdominal aorta. And here you'll see the graft deployed. So now we've excluded the aneurysm rupture. You can see his breathing is wide awake. Both the limbs fill, and he's done great. And this is the post. So it's a ruptured aneurysm, which is a 90% mortality. We were able to salvage with an endovascular approach. Now, this is a now new technology. I actually used one just on Monday. It's called it's a conformable Gore device. So now you can actually torque the graft, because the humans will have angles. We follow them early on with small aneurysms, right? It goes to a screening ultrasound, 3 centimeters. You follow them in your clinic every 6 months or every year, or every 2 years. You counsel them on them. This is his aneurysm, non-con. At this point, he became 5.5 centimeters and has a little bit of inflammatory rind. Here's some kidney cysts on the right. And you can see here how angled it is. It's probably a 60-degree angle. So what we did was we accessed both groins. We blocked off one of the internal iliac arteries and to prevent a leak. And you can see this tight angulation. So we take this device and look at this. The device actually angles. It was pretty new to look at that new technology, so that we can actually torque it and angle it. Finish the deployment. And now the sac is now filling. That big balloon that can burst is no longer filling. The guy's doing pretty well. And you can see here's a scan showing the excluded aneurysm, and the aneurysm sac is actually shrinking. This is another patient of mine that had an aneurysm with what's called a type 1 leak. So it was leaking from the top. So what I did was, you can see all this is leakage, right? It's leakage to die. He was symptomatic, so I accessed his femoral artery in the SFA. And then I deployed a graft. And I used this thing, which is an endovascular suture. Pretty cool. So you could potentially use this elsewhere. But we basically put this screw through the graft into the native aortic wall, and I put a bunch of them. Still had a bit of leak. So I put another cup in, and ballooned it. And then I used this old technology from Julio Palmas, who founded that aortic balloon expandable stent, and deployed that, and that sealed it. And his pain went away, and he's still alive in his 90s now. So kind of a rapid run through complex aortic interventions, one of my passions. But again, you have to own the disease. You have to have a clinic. Otherwise, you shouldn't be doing these procedures. Thank you.